Very good morning. This class is on radiation safety and protection. So these are the contents which include sources of radiation exposure, then risk and doses in dental and maxillofacial radiology, then implementing radiation protection, which includes guiding principle, patient protection, and person protection, then dose limits, then quality assurance, and then continuing education. Starting with the introduction, so it is the sole responsibility of the dentist is to follow the radiation protection program. So in this section, methods of exposure and dose reductions are described that can be used in our dental radiography. Regarding the source of radiation exposure, which includes natural or background radiation, then man-made radiation. So this provides a useful contextual framework to understand the magnitude of diagnostic radiation exposure. All life on Earth has evolved in a continuous exposure to natural background radiation from space and various terrestrial sources. An annual effective dose of approximately 3.1 MSV in US. The global average is 2.4 MSV per year and the typical global range is 1 to 13 MSV. So this is a pie chart showing the contribution of various factors for radiation exposure. So 52% accounts for radon and 12% for terrestrial internal, then 16% for cosmic radiation, then 20% for external terrestrial radiation. And this picture shows a pie chart for man-made radiation, which includes nuclear medicine, consumer products, then occupational radiation, fallout, nuclear fuel cycle, and dental radiation, which accounts for a very meager amount. So this table shows an average annual effective dose of ionizing radiation and the contribution of each factor and the amount of doses delivered by them, which is given in microsievert. So looking into the dental radiology, it is a very minimal amount, that is around 2.5 microsievert. So now coming to the risk and doses associated with dental and maxillofacial radiology. So the basic principle of diagnostic imaging is that the benefit to the patient far outweighs the radiation associated risk. So to satisfy this principle, doses from dento-maxillofacial radiographic examination must be optimized to produce a diagnostically acceptable image. So the dose in dental maxillofacial radiology is very minimal, which will be very less than the threshold. So which will not cause any deterministic effect. Then again, one other principle is that it has to be kept, the radiation should be kept to be minimized to keep the risk of stochastic effect within an acceptable range. So regarding the dose limitation, which is given by NCRP and ICRP. So what is NCRP? NCRP is National Council of Radiation Protection and ICRP is International Commission on Radiation Protection. So they have established a guideline for limitation on the amount of radiation received by both occupationally exposed individual and the public. So this is the table showing both the NCRP and ICRP guideline for occupational dose limit and for non-occupational dose limit. For occupational dose limit, relative to stochastic effect for in NCRP guideline, it is 50 MSV annual effective dose limit and 10 MSV age cumulative effective dose limit. Relative to the deterministic effect in NCRP guideline, it is 150 MSV annual equivalent dose limit to lens of eye and 500 MSV annual equivalent dose limit to the skin and extremities. And regarding the non-occupational dose limit, relative to the stochastic effect, the dose is 5 MSV annual effective dose limit for infrequent exposure and 1 MSV annual effective dose limit for continuous exposure. Relative to deterministic effect, 50 MSV annual equivalent dose limit to the lens of eye, skin and extremities. Regarding embryo and fetus, 0.5 MSV equivalent dose limit per month after pregnancy is known. Regarding the negligible individual dose, it is 0.01 MSV annual effective dose. Now coming to the ICRP guideline, relative to the stochastic effect, it is 50 MSV annual effective dose limit and 100 MSV in 5-year cumulative effective dose limit. Relative to the deterministic effect in ICRP guidelines, it is 150 MSV equivalent dose to the lens of eye and 500 MSV annual equivalent dose limit to the skin and extremities. Regarding the non-occupational dose limit for relative to stochastic effect, it is 1 MSV annual effective dose limit and is higher not to exceed annual average of 1 MSV over 5 years. Relative to deterministic effect, it is 15 MSV annual equivalent dose limit to the lens of the eye and 50 MSV annual equivalent dose limit to lens of eye, skin and extremities. Regarding embryo and fetus in ICRP guideline, it is 2 MSV equivalent dose limit for the pregnancy if pregnancy has been declared. And for negligible individual dose in ICRP, it is not established. So now let us see the effective dose from diagnostic X-ray radiation and equivalent background exposure. So effective dose from various equipment for intraoral X-rays regarding the rectangular collimation while taking the posterior piping using PSP or F-speed film, the effective dose is 5 microsievert. Whereas using round collimation, the effective dose is found to be 171 microsievert. So comparatively, using a rectangular collimation is better. Then regarding the extraoral X-rays, for panoramic X-rays, the effective dose is 9 to 26. For cephalometric, it is 3 to 6. For computer tomography, it is 860 microsievert. For making the skull radiograph, it is 70 microsievert. For making the chest X-ray, it is 20 microsievert. Risk estimates. So what is a risk estimate? A risk may be defined as a likelihood of injury or death from some hazard. So risk is equal to the probability of effect. Risk estimate usually is obtained from high doses and extrapolated to low doses. The primary risk from dental radiography is radiation-induced cancer and possibly the potential to affect the pregnancy outcome. Risk estimates vary depending on several factors such as speed of the film, collimation, and the technique used. There are 3 guiding principles, that is justification, optimization, and dose limitation. So starting with principle of justification, this principle obligates the dentist to do more good than harm. So in this practice, principle influences what patients we select for radiographic examination and what examination we choose. So the next principle is principle of optimization. So it is also referred as principle of ALARA. What is ALARA? ALARA is as low as reasonably achievable. So this principle holds that dentists should use every means to reduce unnecessary exposure to the patient as well as themselves. So the next one is principle of dose limitation. Dose limits are used for occupational and public exposure to ensure that no individuals are exposed to unacceptably high doses. So there are no dose limits for individual exposed for diagnostic or therapeutic purposes. So patient protection. First one is patient selection criteria. So what sort of patient you're going to select for making the radiograph? So it should be in such a way that a clinical and historical finding will mandate to go for a radiograph. So without the radiograph, if we are not able to proceed with the diagnosis or treatment, then we need to advise a radiograph for the patient. The next one is conducting the examination. So conducting the radiographic examination. So it may be divided into the choice of equipment and the choice of technique and operation of equipment and processing and interpreting the radiographic image. Conduction of patient examination depends on film and digital imaging, intensifying screens and film or digital imaging, source to skin distance, rectangular collimation, filtration, protective aprons and thyroid collars, film and sensor holders, KVP, milliampere in seconds, film processing, interpreting the images. So starting with the film and digital imaging, currently intraoral X-ray film is available in 3 speed, that is D, E and F. So E speed film, the sensitivity is equivalent to 2 times the D speed film and 50 times than the regular dental X-ray film. So regarding the F-speed film, which requires an exposure of 75% of E-speed film and 40% of D-speed film. F-speed film has significant desirable diagnostic utility more than E and D film. So having a knowledge about the types of the film, so based on that, And based on the clinical scenario, we need to go for using a film which will have more sensitivity, so that to keep the minimum exposure to the patient as well as to the operator. So this picture shows various type of film, that is D, E and F. So this is the digital sensor. So this offers an equal or greater dose saving than the F-speed film. So in the previous slide I was telling that there are types of film, that is D, E and F, and I was mentioning that F is found to be more sensitive and better when compared to D and E. So when we compare F-speed film with the digital sensor offers a better dose saving, and it is also gives a comparable diagnostic utility. So that is, it gives a better resolution image when compared to an film image. So now coming to the intensifying screens in film or the digital imaging. So intensifying screens are used in making the extraoral radiographs. So what does this intensifying screens contain? They have the rare earth elements like gadolinium and lanthanum. So the importance of having this rare element is that it will absorb the X-ray and produce light, which will convert a portion of the absorbed X-ray into light, and this is the fluorescent process. Thereby it reduces the patient's radiation dose and exposure time. So these are this white area which is seen on either side of the cassette is nothing but your intensifying screen. So when the X-ray photon reaches the cassette, the rare earth elements which is seen in the intensifying screens will absorb the X-ray photon, and this will in turn emit a light, and that light will cause the exposure of the film. So regarding the digital imaging, the image resolution with the digital imaging is comparable to that obtained with the rare earth screen matched with appropriate film. There is no significant dose reduction with the digital system. Source to skin distance. So we know that there are two types of cone available. There is long cone and the short cone. The long cone accounts for 16 inches with 41 centimeter, and short cone accounts for 8 inches, that is 20 centimeter. So using the long source to object distance result in reduction in the exposed tissue volume. So use of longer source to object distance and smaller apparent focal spot size increases the resolution of the radiograph. Now let us see this pic. Can you see the difference between these two pictures? So this is a tube head and this is the cone. This is a long cone and this is a short cone, and compare the area covered by the long cone and the short cone. This area is found to be quite larger when compared to the area covered by the long cone. So rectangular collimation. So what is collimation? It is a method of restricting and confining the X-ray beam to a given area. So collimator is a metallic barrier with an aperture in the middle used to reduce the size of the X-ray beam and thereby the volume of the irradiated tissue. So what are the types? You have round and rectangular type. So this is a round type collimator and this is a rectangular collimator. Can you see the difference here? In a rectangular collimator, the area is covered in excess when compared to the rectangular collimator. Rectangular collimator just matches with the size of the IUPA film. So what is the use of having a rectangular collimator? So it improves the image quality, reduces the exposure, reduces the number of scattered photons reaching the film. Then some types of film holding instruments also provide rectangular collimation of the X-ray beam. The dental X-ray beam are usually to a circle of 2 3/4, that is 7 centimeter in diameter. Now about the filtration. So when the X-ray beam is produced, many energies of photons exist. So many are of such lower energy that they will offer nothing to the production of the X-ray radiograph. So metals such as aluminium, which will absorb the soft low energy rays, are used, and this reduces the patient exposure. So this is the tube operating potential. So below 50 kVp, the minimum total filtration is 0.5. Between 50 to 70, it is 1.5. And between 71 and above, the total filtration is 2.5. Now next is using a lead aprons and collars. So actually we are discussing about the methods of keeping radiation low to the operator and the patient. So in that we are going to look into the lead aprons. So lead aprons are nothing but flexible sheet placed over the patient chest and lap to protect the reproductive and the blood forming tissues from scattered radiation. So recommended for all the intraoral and the extraoral films with protective equivalent of 1/4 millimeter of lead. Next, about the thyroid collar. So this is the thyroid collar. So this blue one is the thyroid collar. The flexible lead shield placed securely around the patient neck to protect the thyroid gland, thereby protecting them from the scattered radiation. So separate shield are a part of lead apron. The thickness is 0.2 mm. So it acts as a secondary measure to protect the patient, and it should not be substituted by use of fast films, lead collimation and aluminum filtration, which are primary means of reducing exposure to the patient. So recommended for all the intraoral films as thyroid gland is exposed to X-ray radiation because of its location, and not recommended with extraoral film because it obscures the information on the film, resulting in non-diagnostic radiograph. Next, coming to the film and the sensor holder. So this is the film and the sensor holder. So this will help us to stabilize the film position in the mouth and reduce the chance of movement. So this will eliminate the need for patient to hold the film in place. So thereby reducing the number of repeat X-ray to be taken and ultimately reduce the exposure to the patient as well as the operator. So these are the pics showing the types of the film holder, that is snap array film holder, precision film holder and RIN XCP film holder. So what is the use of using a film holder? Patient's finger is not exposed to unnecessary radiation, and the possibility of misaligning the X-ray tube and partially missing the film, which can lead to a cone cut, which is also be reduced while using the film holder. Next, about the KVP. KVP determines the penetrating ability of the X-ray beam. When a high KVP is used in the film system, there is more shades of gray, that is the low contrast, than when low KVP is used. So this is two different X-ray which is made with a higher KVP and a low KVP. The one with higher KVP has low radiographic contrast, and the other one which is exposed with the low KVP shows a higher contrast. Next is milliamperage in seconds. Milliamperage in seconds determines the amount of X-ray radiation being produced, which is calculated by multiplying MA with time. So set the MA at the highest setting and then establish the proper time setting. This technique results in the proper use of shorter time setting, which are helpful in avoiding the patient motion artifact on radiographs. So now we'll see about film processing. Radiographs should not be overexposed and then underdeveloped because this practice results in greater exposure to the patient and the operator and can produce images of poor diagnostic quality. So when the radiograph is having a poor diagnostic quality, you need to go for repeat X-ray, and which will cause an unnecessary exposure to the patient as well as the operator. So dental radiograph should not be processed by sight, and manufacturer's instruction regarding time, temperature and the chemistry should be followed. So the use of machines to process the dental X-ray has become widespread. More than 90% of dentists surveyed have reported using a dental film processor. So automatic film processor should be used in the dark room if possible to avoid processing errors. Next, we'll see about interpreting the images. So radiographs are best viewed in a semi-darkened room with the light transmitted through the films, and digital images are best interpreted on a computer screen in a dark environment. So the diagnostic accuracy of the radiographic queries is about 70% or less, and failure to diagnose problem is an increasing source of liability claims. So next we'll see about protecting personnel. So the dental radiologist must use proper protection measures to avoid occupational exposure to X-ray radiation. Example, the primary radiation, scatter radiation and leakage radiation. So this includes protection guidelines and radiation monitoring devices. The protection guidelines, the first one is position distance rule. And position distance rule is followed if there is no barrier available and the operator has to stand at least 6 feet from the patient at an angle of 90 to 135 degree to the central ray of the X-ray beam when the patient is given the exposure. Next is proper operator position. Never hold a film in place for a patient during the X-ray exposure, and never hold the tube head with your hand during the X-ray exposure. And a shielding recommendation, dental radiologist should stand behind the protective barrier. So this is the barrier. You'll have to stand behind the barrier, such as a wall, during the X-ray exposure. Next, we will see about radiation monitoring. So, amount of radiation that reaches the body of the dental radiologist must be measured through the use of personal monitoring devices known as film batches. So, these are the film batches, which consist of piece of radiographic film in the plastic holder. So, these film batches have certain advantages and disadvantages. About the advantages, it is inexpensive, easy to handle and process, and reasonably accurate. And regarding the disadvantages, it cannot be reused and sensitive to heat and humidity and must be changed monthly. So next we will see about the thermoluminescent dosimeter. So the measurement range is 0.1 microsievert to 5 microsievert. And let's say about the advantages. It is not sensitive to heat or humidity and more sensitive and accurate and can be changed quarterly instead of monthly. And about the disadvantages, it's quite expensive. Next, we'll see about the quality assurance. The definition for quality assurance is that it is any planned activity to ensure that a dental office is consistently producing high quality images with minimum exposure to the patient. So, practitioners should remain informed about the safety updates and the availability of new equipment, supplies, and the techniques that could further improve the diagnostic quality of radiographs and decrease the radiographic exposure. We have come to the conclusion of this topic. So it is understood that radiograph is most important diagnostic tool in dentistry. So thus proper protection should be taken while exposing the patient. So these are my references, and thank you for your patient listening.